Now, we all know that about 80 to 168 million people all over the world struggle with this problem of infertility. And the wait is long, and it sometimes is like a dream. The dream of having a child seems to be for life. It doesn't end. So is the frustration and other psychological factors associated with infertility treatment. And almost 1 in every 10 couples experience either primary or secondary infertility. Why do we want to have a baby? Why all of us need to have a child? Now, there could be many reasons for it. It can be a biological need. You want to have a baby to continue the family line. There may be some social compulsions or a psychological desire. And therefore, men and women from all over the world seek various treatments, various remedies to have children through medically advanced treatment like ICSI or IVF. Now, having said that, for most couples, what we see is assisted conception is the last best treatment option. Now, if you see, this is a known fact, I'm sure, to all of you, that infertility is always, the problem of a couple. It's not your own problem or somebody else's own problem most of the time. And every single day when patients come to the doctor or to, the nurses, the counselors, to talk about fertility issues, you will see that, they are very sort of anxiously asking about a hormone profile they should order, or, they sort of talk to you about their general concerns, anxiety, why am I not successful in having a child, why cannot I conceive, these sort of very common questions. Now, when I talk to you, I actually am speaking in terms from the point of view of a lay person, because in our clinic, birth clinic, when I go there, I come in contact with hundreds of patients every day, and they break into tears. So when I talk, I'm not talking to you from the perspective of a doctor, but say from the perspective of a counselor or a nurse or somebody who observes from a distance. So I know the psychological, the social problems which they face on a regular day-to-day basis. 5 factors actually affect infertility, and they are age, second is weight, which Dr. Cascade was talking about. Then you have the pelvic inflammatory disease, and then you have the lifestyle factors and genetic defects. My topic, the lost tribe of infertile race. All, couples coming for fertility treatment feel that they are lost. They are not proper women, they are other. As opposed to womanhood, which is, having a baby, being a mother, is the fundamental aspect of being a woman. And if you can't be a mother, then you stay, for the rest of your life, you stay as the other. So today I'm going to sort of, talk about that psychological problem.
But I've been picking up the pieces so we can remake us again. Take what you need. Take what you need from me. Go when you go home. Take what you need to feel at home.
Now, this is the picture of the Canadian woman, Nadia Suleiman, who had octuplets, 8 children at a time. Now, her case generated an enormous response in the social media at one point of time, and there were a lot of public, debates, discussions, which caught the world by fancy, actually, this thing. But what is a little uncommon for this case is we look at the brighter side, the happy side, that she had 8 babies all in one go. But there is another aspect to it as well. What about those couples who are trying but cannot have babies? That psychological aspect is always lost upon us. When doctors talk to infertile patients, couples, and when you read the books, the typical definition that you see is, it is a shared problem. If you're trying for 1 year, you're having unprotected sex, and you're still unable to conceive, that is what we call primary infertility. That is for the first time. But this is actually what is infertility from the patient's point of view. It is, of course, a medical condition which destroys your dignity, destroys your social life, destroys your savings account, causes a lot of pain, anger, anguish, shock, emotion. And for this, there's a big dent in your pocket. You lose half of your savings throughout the life. Now, here are pictures of 2 couples, First is James and Davina D'Souza. This article came out in Times at one point of time where, this couple had been trying for a long time, for the last 5 years, and they were unable to conceive. And they are still unable to conceive, until a point came when the husband felt that they should stop treatment. And the wife starts crying. She breaks down and says, I don't want to give it a miss. I want to keep on trying. And so a lot of infertility patients, they relate their cases to luck. Mera lucky kuch kharab hai. I was born the unlucky one. This is the typical thing they have to say, and the role of fortune plays a very big role here, part here. The next person showing here, shown in this picture is Gareth Down. He and his wife Natalie, after 10 failed cycles of IVF and spending a couple of $1,000 on the treatment, they were blessed with a son. And after they had their son, they, talked of luck in another way. To them, luck was nothing. They said, we tried for it and we were almost ruined. We have been sort of, reduced to being beggars. And after so much worry, if we have a son, how can we say it is because we are lucky? We were hardly lucky. You are looking at one side of it. What about the other side? How do I bring up my child now? So these are the 2 kind of, opinions of 2 different patients. Now, role of luck is perceived, some think they are lucky, some think they are unlucky. So this is how it works. If I show you this video, you'll understand how patients talk about infertility and the treatment.
Destroyed me. A baby like
Sound.
this was all I wanted, and what I couldn't have. My background might resonate with some of you. There'd been some rough times in my childhood, but I had coped by becoming very studious and very, very determined. That was how I came from Norfolk, Virginia, to Harvard College and law school, and from there became a partner in a major Boston law firm. I thought I had made myself unstoppable until I hit a glass ceiling, but not the one you're probably thinking of. The glass ceiling that upended me turned out to be the glass petri dish that holds embryos in an IVF lab. I was in treatment for 2 years and did 5 cycles of IVF.
So you see, this is nothing atypical, this is common. And one of the things I see, some of the patients who've been facing regular failures, they get so upset They get so annoyed that sometimes they walk into the clinic, start shouting to the nurses, to the counselors, that the doctor is here, he's a mercenary, he knows nothing, but how to earn money. We are being cheated, and yet there's no success. This is, I have decided that I'm going to tell the birth people to play these videos in our clinic. After giving this lecture, this talk to you, I have realized myself that unless you show these sort of recordings to other people, they think they're alone. They think only they are the ones to be cheated, and they are having so many failures. And have a look at this video, listen to this video once.
Let me just share with you just a few of the things we've lost. That not only will we never have children, but we'll never create our own family. We'll never be able to correct the wrongs of our own childhood by doing things differently with our kids. We'll never watch them grow up, never hold their hot little hand in ours, never throw children's birthday parties, never take that first day at school photo. We'll never see them maybe grow up, graduate, get married and have their own kids. We'll never be grandmothers and never give the gift of grandchildren to our parents. We'll never stand shoulder to shoulder with our siblings and watch our children play together. We'll never be the mother of our partner's children and hold that precious place in their heart. We'll never be part of the community of mothers in a society and never be considered a real woman in a society that equates motherhood with womanhood.
And, there's a point I've heard people saying, many people, and here I'm talking about the Western world, one of the women who said that, when she goes home for Christmas, there's a homecoming, and all her siblings, her sisters, her brothers, and their children, they all sort of, get together in a place. At night, if there is any shortage of rooms, what happens is, she is always asked to sleep on the sofa. And her sisters and brothers who have children, they are given the bedroom. So you see the psychological aspect. They always feel every little thing and they end up getting hurt. So they go through this mania, the sense of irritability, depression, anger. Why are we different? Why are we treated differently from the rest of the world? And this is not fair. So when these patients, these couples face such anxiety, such stress, these are the warning signs. You should counsel them to go to a psychiatrist or a psychologist, or speak to you to bear their hearts out. Tell them they must do some exercise, some meditation, some yoga to help them fight this depression. Because at the end of the day, if you are not psychologically well enough, you cannot withstand the pressure of the treatment. That is very important. I'm going to talk about patient-centered infertility care because, we've been sort of discussing, we've been hearing, comments from Dr. Jaideep, and it's been repeated by, Dr. Kastkir as well, that how counselors, how nurses, how the health sector, people, professionals play an important role in bringing patients, making them understand, and then sort of, providing the right sort of encouragement to go forward, to hold on, to that strength, fast losing strength, so that, at the end of the day, they begin to see light at the end of the tunnel. So what are some of the carry-home messages? You have to tell patients when you're counseling, some may be overweight, some may be quite advanced in age who come at a later stage for their treatment. So you have to sort of counsel them about the negative lifestyles and tell them these are reversible. You have to reduce your weight, you have to look after yourself, have a healthy diet, have the right sort of tests. So inform them, talk to them about the negative lifestyle, support them to change their ways of life. Provide the necessary information that they require at each step of the treatment and involve both the partners.
What is
And
person-centered care?
this is basically a sum up of what a patient-centric fertility care ought to be.
It means that care is coordinated, tailored to the needs of the individual, underpinned by dignity, compassion, and respect, and enables them to live a fulfilling life. Seems like a no-brainer. Don't we already do that? Actually, it's not standard practice, but it should be. Is it worth it? In a word, yes. Person-centered care can have lasting benefits. There is evidence that it improves health outcomes, care quality, and patient experience. On the professional side, it enhances staff satisfaction. If we want to adopt it, fundamental changes to care are required. So, how do we put it into practice? There are lots of things we can do to develop people's roles in health services and to unlock their person-centered potential, to get health and care services working better together, and to help people to have the knowledge, the skills, and the confidence to work differently with their health.
Next, you come to fertility preservation. Now, we all know, we've been discussing, hearing things from in the morning, since morning, that fertility decreases as your age sort of increases. So, much research has been conducted towards preserving female fertility before one gets too old. And also, some people may be diagnosed, when they're diagnosed with cancer, what they would like to do is come to the clinics to freeze their eggs before treatment, because we all know that when you go through chemotherapy or radiotherapy, due to these exposure to radiation, it sort of, diminishes your, it sort of has a toxic effect on your ovarian reserve and diminishes the ovarian function. So several laboratories now are doing cryopreservation. It's a very common thing following an IVF cycle, but again, these sort of treatments can be only affordable to those who have a good financial backup. So this also gives, this raises again legal issues as well, social concerns, ethical concerns.
Now, what's the age limit for having IVF or IUI? I mean, is there a limit?
Well, success rate drops. It drops significantly in women after 42 who are using their own eggs.
Yes.
So then there becomes the option potentially of donor eggs. So in that situation, women, and some women have premature ovarian failure. So in their 30s, their ovaries unfortunately stop producing eggs. And so even for those women, then the option becomes using donor eggs. And so those are eggs from anonymous donors, and those women are younger, so the age-related changes that affect fertility aren't there.
Now, what if someone goes through these procedures and they have leftover either eggs or embryos? What happens to those?
They freeze them.
And that's based on what the patients want to do. So if you have embryos frozen, then, and your family is complete and you still have embryos frozen, there's the option of donating embryos. Patients discard embryos.
Can you sell them?
No.
No.
So when it comes to donation, embryo donation or sperm donation, there are many ethical issues concerning these things, because you have risks associated with this kind of treatment. For example, when you donate an egg, sometimes, you donate eggs, you can have ovarian hyperstimulation syndrome, or, you can also have many risks which are concerned with surgery. And this remains a central concern about a woman who has come to give her eggs. And she has to sign the consent form. I mean, as counselors, as nurses, you have to tell the patient that there are certain, risks associated with donating eggs. And the other thing is, all the donors must donate voluntarily. There should not be any pressure as a result of which they come here, because many are forced to do so, with the prospect, because there's the prospect of financial gain. So commodification of women or eggs is something which the law cannot allow. So these are certain brownie points. You remember, Make sure the patients understand your advice. Tell them the psychological, the ethical, part of the entire treatment, the pros and cons. Tell them about their rights, their responsibilities, and with each treatment, here comes the legal areas which need to be sorted out and to rightly explain to them. Tell them how this treatment will impact their lives. Double check always about the information. When you counsel them, tell them something, make them repeat it. This is the best way to understand that they have understood what you have been telling them all the while. And explore the areas of stress, help them to manage stress, and help them to stay healthy and happy in order to undergo this very psychologically excruciating kind of, psychologically sort of a psychological treatment. Because as I said in my earlier lectures, earlier talks as well, this stress-related factor is very important. You need to stay happy, you need to be sure of what you're doing before you make an informed choice. Thank you.
So with this few words, I would like to start with the first session discussion today with a very basic male and female reproduction and what is the physiology of conception, how the life begins. Now we can talk about this for the whole day. So I've made it very short and simple, but if anyone wants anything in details, we'll be able to go through it according to requirement. Now what is human fertility? In very simple term, there are hundreds and thousands of sperms, actually millions of sperm, they are coming to fertilize one egg. So sperms are many in number and majority of them are actually wasted. If you say wasted, so wasting is not a right term, maybe are being utilized so that one of them can actually enter the egg. Now after the sperm, if you look at the egg is a very complex cell and it's a very large cell. It's the largest cell in the human body. It has a very similar structure to any other cells. It has a nucleus, it has mitochondria, ribosome, but as I told you, it has got a shell called zona pellucida. And it is surrounded by some important cells like granulosa cell and theca cell, because these cells actually help the egg to produce different hormones. So it is not the egg itself which is producing the hormones, but the cells surrounding the egg. I'm sure you have heard about this term PCOS or polycystic ovarian syndrome. Now what happens in polycystic ovary? There are multiple follicles, and because there are multiple follicles, there is a very high level of estrogen. Estrogen sends a negative feedback because there's a hypothalamic-pituitary ovarian axis. Hypothalamus sends stimulation to the pituitary, pituitary sends stimulation to the ovary. Now, when there is enough estrogen, there's a negative feedback to hypothalamus and pituitary, and then with this very negative feedback, FSH level becomes low. Whereas with the high estrogen level, LH stimulation takes place. So FSH is low and LH is high, which we see in polycystic ovary. And because FSH helps in follicular development, if there are too many, too high estrogen, too low FSH, then follicles are not going to grow. Now there are many predictors of ovarian performance. When we are treating a patient, we need to know what are the factors that determines ovulation. They are like age of the patient, the reason of infertility, body mass index. Obesity is a big problem, and so is a thin, low body weight. Now, we have been talking about AFC, that is determined by ultrasonography. Now, explain your patient, the ultrasonography is better done by transvaginal rather than transabdominal, because you can go very close to the uterine structure. You do not need full bladder. Many ladies are embarrassed दे डू नॉट वांट टू हैव ट्रांसवेजाइनल, वो चाहते नहीं, वो कहते नहीं एब्डोमिनल कर दीजिए. सो वी ऑलवेज से नो, इट्स विल बी डन बाय ए लेडी गायनेकोलॉजिस्ट और ए लेडी sonologist. Don't be embarrassed, you don't need full bladder. But of course, if that lady is supposed to have any other test like vaginal swab लेना है, वो पहले कर लीजिए, क्योंकि अल्ट्रासोनोग्राफी का टाइम वो जो जेल हम लोग यूज करते हैं, वो जेल से स्वैब रिजल्ट्स ठीक नहीं आएगा. सो दिस सॉर्ट ऑफ सम कॉमन सेंस, किस ऑर्डर में करना है ये आपको याद रखना है. नाउ हर प्रोसीडियर के लिए कंसेंट लेना बहुत जरूरी है, एक रिटन कंसेंट लेना जरूरी है. तो वो कंसेंट हम लोग हर क्लिनिक का अलग अलग होते हैं. पेशेंट को बताना है, हम अल्ट्रासोनोग्राफी से ही पॉलीसिस्टिक ओवरी है या नहीं पता कर सकते हैं. हर टाइम ब्लड टेस्ट का जरूरत नहीं है, लेकिन वो सिर्फ ट्रांसवेजाइनल से ही हो सकता है. फॉलिकल धीरे धीरे ग्रो करते हैं, जिसको हम लोग कहते हैं फॉलिकुलर मॉनिटरिंग. डे इंजेक्शन देने के बाद हम डे 8 डे 10 में फिर मॉनिटरिंग करते हैं. उसी से पता चल जाता है कैसा फॉलिकल साइज इंक्रीज होता है. हम फॉलिकल जब रप्चर हो जाते हैं उसको देख सकते हैं. सो ओव्यूलेशन हो रहा है या नहीं ये जानने का लिए आगे का दिन हम प्रोजेस्टेरॉन चेक करते थे, अब वो बंद हो गया. अब हम क्या करते हैं, अल्ट्रासोनोग्राफी मॉनिटरिंग, फॉलिकल था, अचानक चला गया, पेल्विस में कुछ फ्लूइड मिल गया. पेशेंट्स आर ऑल्सो वेरी हैप्पी बिकॉज दे सी, दे वेरी एनकरेज्ड. नाउ हम एंडोमेट्रियम देख सकते हैं अच्छी तरह से. एंडोमेट्रियम फॉलिकुलर फेज में कैसा होते हैं, बहुत थिन होते हैं, ट्रिपल लाइन होते हैं. सिक्रेटरी फेज में वो थिक हो जाते हैं, और उसका साथ सॉरी आई डिडंट यूज एंड सिक्रेटरी फेज में थिक हो जाते हैं और डेंस हो जाते हैं. जो आपने देखा है ये बहुत इंपॉर्टेंट है. हम एंडोमेट्रियम जो है बीच में उसका साथ मायोमेट्रियम को कंपेयर करते हैं, और उस साइड में आप देख रहे हैं एंडोमेट्रियम बहुत थिक हो गया. ओव्यूलेशन का बाद में ये होते हैं, लेकिन अगर आईयूआई का पहले ही ऐसा हो गया वो बहुत सुटेबल नहीं है. एंडोमेट्रियम अगर थिन रहते वो एक प्रॉब्लम हो सकता है, टीबी का वजह से हो सकता है, इन्फेक्शन की वजह से हो सकता है. सो हम अंडरस्टैंड कर सकते हैं अच्छा ओव्यूलेशन हो रहा है लेकिन प्रेगनेंसी क्यों नहीं आ रहा है. अभी 3D अल्ट्रासोनोग्राफी से हम एंडोमेट्रियम का वॉल्यूम नाप कर सकते हैं, शेप देख सकते हैं कैसा है. हम यूट्रस का ब्लड फ्लो भी नाप सकते हैं, इसी का एक स्कोर है, धीरे धीरे कैसा ब्लड फ्लो ज्यादा होते जाता है. और जब एंडोमेट्रियम एकदम रेडी हो जाते हैं, जिसको हम रिसेप्टिव एंडोमेट्रियम कहते हैं, इट लुक्स लाइक दिस, लॉट्स ऑफ ब्लड सप्लाई टू द एंडोमेट्रियम. एंडोमेट्रियम का अपीयरेंस हम पता कर सकते हैं. जब इरेगुलर एंडोमेट्रियम होता है, कभी पॉलिप हो सकता है. सो आपको पेशेंट को काउंसल करना है, बताना है जी आप अल्ट्रासोनोग्राफी कर लीजिए, बहुत सारी चीज पता हो जाता है. और बार बार करना है, डे 2 डे 3 में एक बार देखना है, डे 8 डे 10 में देखना है, ओव्यूलेशन का बाद भी हमको देखना है. पॉलीसिस्टिक ओवरी छोड़ के हम ओवेरियन सिस्ट पता कर सकते हैं. हेमरेजिक सिस्ट होते हैं, कभी कभी सिस्ट का अंदर ब्लीडिंग आ जाता, कभी एंडोमेट्रियोसिस होता है. हाइड्रोसाल्पिंग्स, फैलोपियन ट्यूब में पानी जमा होने से, वो भी हम देख सकते हैं. ट्यूबरकुलोसिस जो हमारा देश में बहुत कॉमन है. HSG हिस्टेरोसैल्पिंगोग्राफी एक स्पेशल टाइप ऑफ एक्सरे है, वो हम लोग इतना ज्यादा अभी नहीं करते. इफ यू आस्क मी, हम HSG पसंद नहीं करते, हम सलाइन सोनोग्राफी पसंद करते क्योंकि उसी में दर्द नहीं होता है. हम ये मजाक से कहते प्राइवेट क्लिनिक में जो आते हैं, हम लोग सब प्राइवेट क्लिनिक में काम करते हैं, देयर इज नथिंग रॉन्ग विद गवर्नमेंट हॉस्पिटल, बट इन गवर्नमेंट हॉस्पिटल आप जो भी करें पेशेंट को मान लेना पड़ेगा. प्राइवेट क्लिनिक में ऐसा ही आपको करना है, अगर अच्छा करेंगे दर्द नहीं होगा फिर वापस आएगा, नहीं तो वापस नहीं आएगा. लेकिन HSG कभी कभी करना पड़ता है, जैसा टीबी में करना पड़ता है, क्योंकि ये जो शेप आप देख रहे हैं, इरेगुलर यूट्रस का शेप देख रहे हैं, फेलोपियन ट्यूब का उधर देखिए बीडिंग अपीयरेंस है, ये दूसरा टेस्ट से पता नहीं चलता. हम एडिनोमायोसिस आपने सुना है, यूट्रस का अंदर मायोमेट्रियम में खून जमा हो जाता है, एडिनोमायोसिस इज अ प्रॉब्लम दैट कैन बी डिटेक्टेड. फाइब्रॉइड हम पता कर सकते हैं, एंडोमेट्रियम का अंदर पॉलिप पता कर सकते हैं. सबम्यूकस फाइब्रॉइड, छोटा सा फाइब्रॉइड कैविटी का अंदर है, वो देख सकते हैं. यूनिकॉर्नुएट यूट्रस, किसी का यूट्रस सिर्फ एक तरफ साइड में हिला हुआ है, वो आप देख सकते हैं. देखिए यहाँ पे एक यूट्रस नॉर्मल है और दूसरा रूडिमेंटरी हॉर्न है. सो ये इसी में पेशेंट का बहुत पेन होता है. कभी कभी रूडिमेंटरी हॉर्न में प्रेगनेंसी आ जा सकता है, वो प्रेगनेंसी रप्चर हो जाता है. सो बहुत सारी चीज, बाइकॉर्नुएट यूट्रस, दो यूट्रस, दोनों यूट्रस में एक साइड प्रेगनेंसी आ गया, एक साइड प्रेगनेंसी नहीं आया. यूट्रस डायडेल्फिस, कंप्लीटली दो सेपरेट यूट्रस. आगे का दिन लैप्रोस्कोपी नहीं करके पता नहीं चलता था, अभी पता चलता. सेप्टेड यूट्रस आप देख सकते हैं, आर्कुएट यूट्रस, टी शेपेड यूट्रस. और ये है सलाइन सोनोग्राफी. अल्ट्रासोनोग्राफी का टाइम थोड़ा सा पानी एक पीडियाट्रिक फोलिक कैथेटर से हम यूट्रस का अंदर डालते हैं, और फोलिक कैथेटर से सलाइन इन्फ्यूज करते हैं, उसी टाइम आप अगर पिक्चर ले ले, देखिए ऐसा इरेगुलर, अगर ऊपर में जो देख रहे हैं वो छोटा सा पॉलिप है, नीचे देखिए एकदम नॉर्मल है, उस तरफ देखिए एक फाइब्रॉइड है। कभी कभी रेयरली हम लोग एमआरआई और पेट स्कैन भी करते हैं, उसी से ट्यूब ओवेरियन मैस, वो टी। अल्ट्रासोनोग्राफी का बाद एक बहुत इंपॉर्टेंट इन्वेस्टिगेशन एज वेल एज ट्रीटमेंट है एंडोस्कोपी। एंडोस्कोपी में हिस्ट्रोस्कोपी है, लैप्रोस्कोपी है। इसी का लिए आपको कंसेंट लेना है, इसी का कुछ कुछ कॉम्प्लिकेशन है, कुछ कुछ सुविधा है। साइंटिफिकली ये कंसेंट आप फिलअप करके साइन मत कीजिए। कभी कभी ऐसा होता है आप कंसेंट लेके आप साइन कर दिया, पेशेंट हट से मोबाइल फोन से एक पिक्चर ले लेता है जब डॉक्टर का साइन नहीं है, बाद में डॉक्टर साइन करने के टाइम एक दो पॉइंट ऐड कर दिया, सो लीगली आपने गलती किया। सो पेशेंट को आप एक्सप्लेन कीजिए, लेकिन साइन करना है डॉक्टर के सामने। डॉक्टर अगर आपको कहे बहुत सारी जगह पर तुम पूरा कर दो, यू कैन गो एंड टेल, नहीं हमारा ये सब ट्रेनिंग प्रोग्राम हुआ था, वहां पे बताया गया था। किसका रिस्पॉन्सिबिलिटी है? डॉक्टर का रिस्पॉन्सिबिलिटी है। सो डॉक्टर का सामने पेशेंट को साइन करना है। आपने समझा सकते हैं लेकिन आप साइन नहीं कर सकते, ठीक है। सो ये सारी चीजों का लिए हम लोग कर सकते हैं। ओव्यूलेशन का प्रॉब्लम, ट्यूब का प्रॉब्लम, यूट्रस का प्रॉब्लम, हम ओवेरियन ड्रिलिंग कर सकते हैं। हम टाइम की वजह से दिखा नहीं सक रहे, एंडोमेट्रियोसिस का ट्रीटमेंट हम कर सकते हैं। ट्यूब का कोई इंफेक्शन हो, ऑपरेशन का बाद एडिशन हो, स्टेरिलाइजेशन हो गया, जेनिटल ट्यूबरकुलोसिस, सब हम देख सकते हैं। यहाँ पे हम देख रहे हैं फेलोपियन ट्यूब के अंदर हम डाई पुश कर रहे हैं, एक फेलोपियन ट्यूब खुला है, दूसरा फेलोपियन ट्यूब बंद है। ये फेलोपियन ट्यूब से देखिए डाई आ रहा है, दूसरा फेलोपियन ट्यूब का मुंह देखिए बंद है। हम ऑपरेशन से इसको खोल सकते हैं, हम बाद में आपको दिखाएंगे दूसरा कोई टाइम में, अभी टाइम शॉर्टेज है इसीलिए। फेलोपियन ट्यूब में जो ब्लॉक होता है हम हिस्टेरोस्कोपी से फेलोपियन ट्यूब का ब्लॉक को ओपन कर सकते हैं। बहुत ही सिंपल टेक्निक है, सवेरे भर्ती होके दोपहर को घर चला जाता है। देखिए ये कैथीटर से हम फेलोपियन ट्यूब खोल सकते हैं। बहुत सारे पेशेंट का आईवीएफ का जरूरत नहीं है, ये आप ब्लॉक खोल सकते हैं। ये ब्लॉक खोलने के बाद देखिए डाई हमने पुश कर दिया। अपने आगे लेक्चर में सुना है पेल्विक इन्फ्लेमेटरी डिजीज, क्लैमिडिया इन्फेक्शन, इसमें बहुत कॉमन है, सेक्सुअली ट्रांसमिटेड डिजीज में बहुत कॉमन होता है। सो ए वेरी सिंपल टेक्निक। हम बहुत सारे पेशेंट जिसको आईवीएफ का सजेशन दिया गया था, ये ऑपरेशन से हम कंप्लीट किया है। सो इनफर्टिलिटी में इट हैज टू बी रिप्रोडक्टिव मेडिसिन एंड सर्जरी। आप मेडिसिन से ट्रीट कीजिए, लैब का ट्रीटमेंट कीजिए और सर्जरी कीजिए।
गुड मॉर्निंग एवरीबडी, और बर्थ कोलकाता की तरफ से आप सबको नमस्ते। सो माय टॉपिक टुडे इज इनफर्टिलिटी लेबोरेटरी इन्वेस्टिगेशन। सो जब पेशेंट हमारे पास आते हैं, हम उनको कैसे क्या क्या टेस्ट करते हैं, जब उनका प्रोसीडियर होता है तो क्या टेस्ट करते हैं, एंड जब प्रोसीडियर के बाद अगर मिसकैरेज होता है या कोई मेडिकल कंडीशन होता है तो हम उसके लिए क्या क्या इन्वेस्टिगेशंस करते हैं, उसी को लेकर हम इस पे चर्चा करेंगे। दैट्स द टॉक दैट आई एम गोइंग टू प्रेजेंट। सो कैन वी स्टार्ट? सो फॉर द मेल पार्टनर जो सबसे इंपॉर्टेंट होता है शुरुआत में जब हमारे पास आते हैं इज द सीमेन एनालिसिस और द स्पर्म काउंट। तो जो सीमेन एनालिसिस होता है, इसका प्राइमरी जो काम होता है कि हम देखते हैं द मैन्स द हेल्थ एंड द वाइटलिटी ऑफ द मैन्स स्पर्म। सो जो स्पर्म होता है उसका जो काउंट, उसकी मॉर्फोलॉजी, उसकी मोटिलिटी, ये सब जानना जरूरी होता है टू स्टार्ट the procedure of treatment. Now this sperm sample is brought into the lab and we use a method called sperm chromatin dispersion method. This is, before I go into the explanation of further explanation of DFI or the ranges, I want to explain what DFI samples actually look like after the test. So this is a good quality sperm. So these sperms have a good DNA integrity because ये जो sperm cell है, इनके head के पीछे आप देखेंगे there is a halo. The halo means like a big light-like projection behind the head. If the halo is double the size of the head as seen in this sample, it is a good sample. And the next one are cryologs and cryovials. Cryologs are basically used for storing embryos and oocytes, and cryovials are used for storing semen samples. And lastly, we've got the liquid nitrogen tank where the cryovials and the cryologs are stored. So the IUI workup Basically, it's the intrauterine insemination that I'm going to talk about very quickly. Initially, the IUI workup is basically the male partner is screened. I've already told you that before. The sample is collected, and while the sample is collected, make sure that no spermicidal chemicals are being used in the process of collection. The sample is now the sample preparation. There are 4 methods by which the sample can be prepared for IUI. The simple washing technique, then there is a gradient method, there's a swim up method, and magnetic activated sorter method. Once you've chosen your preferred method and you've got your semen sample or your sperm sample, the sample is placed in the uterus using an IUI catheter. The picture of that is on the right hand side of the image as you're looking at it. And the amount is 0.2 to 0.5 ml of prepared sample. It is transferred at the time of ovulation, and after the sperm sample is put in the uterus, the patient is asked to be immobile for about 10 to 15 minutes.